I would like to invite you to the last day's proceedings of this international colloquium. And just a small announcement that we start with a Skype discussion with Professor Fran Baum, who will be on screen once we call her. That's me. She comes on. And this will last for about 10 minutes. And soon after that, we start with the morning's session number 7. Okay, I know it's Saturday and it's the last day, so hopefully by then the hall fills up as well. But let us start.
Hello?
Hi, Fran. Yes, Fran, I can hear you. Good afternoon.
Hi. Good afternoon. Well, good morning to you.
Yes, thank you. Just a moment, you're not coming through the sound system yet.
Okay.
Now we hear you.
Good. Hello. Good morning.
Good morning, Fran. This is the ITM IPH Colloquium 2013.
Yes.
And this is Werner speaking.
Hi, Werner.
Hi, how are you?
Yes, good.
First of all, a very big thank you for doing all these efforts.
That's all right. I'm just sorry that the visa didn't work out. But yeah, I think the best we could do was the recording.
Okay, let's just go over the questions that you already saw either on the blog or on the Facebook page. There was first this question of our colleague Prashant, who sent in the question all the way from Antwerp, and he said the case for social determinants and health at PHC is clearly made, but how does a health worker at the PHC level, primary healthcare level, or the district level incorporate such approaches in year-to-year health planning? I find often that this requires much more engagement of the local governments or political establishments, which are looking for quick wins. How does a health worker who is convinced of this approach gather the critical mass locally to achieve the support of the political establishment and the governance? That, for me, having worked at such level, is a very great challenge. The answer to it is yet unavailable. What do you say to that?
Well, I mean, I think it is a challenge, and I think it's particularly, I mean, I don't think that an individual health worker should take that responsibility. I think it's the responsibility of the health system to develop a comprehensive approach to social determinants. And if there is that kind of planning framework that comes down from the top of the health system through any regional structures to district structures, then there is a much stronger mandate for workers on the ground to be able to look at how they can respond to social determinants. And there's obviously a limit to what can happen within the health sector. But I think, for instance, we've just started some work to look at a social health tool that can be routinely used in clinical interactions so that clinicians, nurses, doctors, whoever, can really get a sense of what social determinants are affecting the lives of the people that they're working with, and then try and take that at least a bit into account in the clinical encounters, rather than just assuming that people's lives are all going well. So I think that's one way. And then I think there's the kind of taking the action with local government, becoming an advocate for the health of the community. I think that's an important role of community health workers at the local level. But it really is about a systems approach. And I think, you know, if a health worker's working in isolation and hasn't got support from their managers and from the district and higher levels of the health system, then it's very difficult for them to respond to social determinants.
Thank you, Fran. We have a related question which came only in this morning. I don't know if you've seen it already. It comes from Dr. Jalam Singh Rathore, and he says, "Thanks for a wonderful presentation and talks. It's a grateful feeling to be part of the colloquium, but I have doubt when we talk about social determinants of health, people start talking about integration, intersectoral coordination with other sectors or departments, working for all those things which have impact on health. I feel what we really need to do is open doors for people who are working in rooms just attached to ours or at same floor and building where we are working. We talk and work on intersectoral coordination with other sections, units, departments within the department. Is that it?"
I don't quite follow the question, sorry, and I hadn't seen that one. What is the question saying, that it's too hard to do intersectoral collaboration?
Apparently, Dr. Singh asks if it's just that, working with other departments who are related to health.
Well, I mean, I wouldn't say that's a just. I mean, I think, you know, there's now been quite a lot of evidence about what makes collaboration across sectors work. And as I said in my talk, I think the Health in All Policies approach really builds on healthy cities and other approaches at the local level. And it usually, I mean, I think the important thing is, if health is going to work with other sectors, is to look at not just how you can achieve health goals, but the other sectors clearly want to achieve their goals, whether that's to do with good urban planning, or it's to do with good education or transport or whatever. And certainly the experience in Adelaide that the Health in All Policies unit in health has found very strongly is they, you know, because they're working within bureaucracies, they really have to look at win-wins. And that only works because they have the mandate from the head of government, you know, that the Health in All Policies approach is driven by Premier and Cabinet. I don't think it would work if it was just driven by the health sector. And then it's not, you know, it's not easy work. It's quite hard to work across sectors. And, but on the other hand, I think that when it does work, then people get a great deal of satisfaction out of it, because they really feel that they're contributing to health and well-being, and that usually makes people feel that they're going to make a difference.
Thank you, Fran. One related question, but much clearer, I think, comes from Professor Bart Creel from ITM. He starts saying, excellent presentation, very grateful for that. And he goes on, I tend to believe that one of the obstacles in effectively doing something about social determinants is to show practitioners, policymakers, and other interested actors that it is possible and doable. For many, the task seems so dauntingly complex and difficult and out of reach. Hence the relevance, I think, to document small-scale, even modest initiatives, experiences and cases, so as to give confidence and provide inspiration to people who basically share the analysis to engage into real action. What would you say on this?
Yeah, I think he's really right. I mean, I think sometimes with words like social determinants, it becomes a rhetoric, and having definite case studies of where things have worked, where things have gone well, or even where they haven't worked and why they haven't worked are really helpful. And I think the more case studies we can build up and establish, then the more people think, yeah, okay, I could do that in my community. That makes sense. I can see how that could work well. So I'd really agree that we really need to look at specific examples and build on those as much as we can.
We have a very last question then. It comes from ITM staff Upendra Bojani, and he says, thank you very much for sending in a recorded video message. It was as if you were talking to us in person, which is the same now, I think. And then he says, dear friend, could you in a few words make distinction between old and new public health terms you often use?
Yeah, well, I think we have to look at where the terms came from, and the new public health was really developed in the 1980s, I think, around the time of the Ottawa Charter for Health Promotion, the WHO Ottawa Charter. And it really was trying to draw the distinction between the old public health that had tended to focus on physical environments, on issues, you know, like providing good water, sanitation and housing. And of course, that's all really, really important. And you know, and meeting in India, clearly that's still a really big issue for populations. But what the new public health said, that equally important were kind of social and behavioural elements of public health, and that we needed to do both. And I think also increasingly, particularly in the last decade or two, we've also looked at kind of the ways in which some of the really broad organisation of society affects health. So, you know, the big example there could be trade and health, and thinking about how trade agreements, how the operation of transnational corporations are also really affecting our health. So I think the big difference is that the old public health was seen to focus just on physical environments, and they're still important, but the new public health really looked at sort of a broader range of determinants of health. And the other thing I think it did was to really focus on the importance of empowerment and participation, and saying that actions for public health shouldn't just be top down, but they should also be about working with people in their local communities, involving people wherever possible, and ensuring that the things that were done empowered people rather than left them feeling disempowered.
Because the new public health also takes into account the power inequities.
Yeah, absolutely. And if you look at the report of the Commission on the Social Determinants of Health, of course, the whole second part of our recommendations were about power, money and resources, and recognising who the really powerful players are in the global economy and the impact that they're having on all our health in both poor countries and rich countries.
Thank you, Fran. We know that you have been travelling yesterday from London to Adelaide. You should be very tired. We wish you...
no, I'm okay. I had a good sleep. So.
Okay. Anyway, we wish you a fine and restful weekend. And we thank
and
you.
again, I'm really sorry I can't be with you. I would love to have been there,
You
and
don't
I'm
have
glad
to
it's
be
all
sorry.
going really well.
Okay.
Bye-bye.
Thank you, Fran. Bye.
Bye.
I would like to introduce the 7th session and the chair and the co-chair for the session. The chair for the session is Sri Krishna Rao. He's a health economist and works as senior health specialist at the Public Health Foundation of India. He's also visiting faculty in the Health Systems Program, Department of International Health, Johns Hopkins University. His research interests include the areas of health systems, health financing, and program impact evaluation. Thank you so much for being with us, Krishna. And the co-chair, Professor Bart Creel, who is not an unknown face, is a medical doctor by training. After graduation, he worked shortly in Belgium as a GP and a hospital doctor in wards for internal medicine. Then worked in Congo in the 80s as a doctor at district hospital at district level for 7 years. His MPH is from London and a PhD at the Free University of Brussels. Joined the Public Health Department of ITM in the early 90s, and I've had the privilege of being taught by him. He's been there for the last 20 years. He's currently professor in public health, and his domains of interest include the organization of healthcare delivery systems at the local level and the study of social health protection arrangements. He was also director at the Public Center of Social Welfare in his home municipality during 8 years in the period 2001 to 2008. Now, this is an unusual face. And he's been deeply involved in the institutional collaboration between ITM and IPH. I thank you, Professor Bart, for being with us this morning. And I hand over the session to Sri Krishna Rao and Bart for the rest of the morning.
Thank you very much. A very warm welcome to all of you. This session, which is session 7, is on the control of neglected diseases and health system strengthening in Asia. So I'm happy to chair this session with Bart. I'll start by introducing our 2 keynote speakers. We have a very interesting lineup of presentations and speakers, and we'll talk about each of the speakers as we go through, but first the keynote speakers. So some of you may already know, or many of you may already know, Bruno Marchal. He's from Belgium, as you might have guessed. He's based at the Institute of Tropical Medicine in the Public Health Department, medical doctor by training. After graduation from medical school, he worked for 6 years in Kenya, where he was a medical superintendent of a hospital, after which then he did his MPH at ITM. Recently, in 2011, he completed his PhD from the Free University at Brussels in medical sciences. His fields of interest are quite varied. They include strategic management of health systems with an interest in stewardship, methods in health systems research, and theory-driven evaluation. And I understand that he is one of the prime movers in the department in Antwerp on new thinking on health systems research. So welcome, Bruno. Our second esteemed keynote speaker is Professor Virasakdi. Professor Virasakdi is from Thailand, where he teaches and does research at the Prince of Songkhla University. He's a medical doctor too, with a specialization in tropical medicine. He trained in epidemiology in Australia, and he's been very active in teaching and research, and has over 100 international publications. He's very active as a policy advisor for both the Thai health authorities and for several international organizations. So welcome, Professor Virasakdi.
Yes, thank you, Mr. Chair. Good morning to all of you. We have this morning two keynote speakers. Bruno is going to present us a framework to appreciate whether and how disease control programs could actually strengthen general health systems. We believe this is a very timely analysis related to a very up-to-date subject that is being hotly debated in the international health policy arena. The second keynote speaker, Professor Virasakdi from Thailand, has equally a very interesting, even if a bit an unexpected view on the relationship between disease control and general health systems. Actually, he discusses whether and argues whether the current emphasis on universal health coverage, and Thailand is an excellent example there, could not go at the expense of disease control programs. So plenty of material for, we believe, a good debate. Now, we were asked initially by the organizers to come up with one or two possible provocative questions or provocative statements. And actually, in discussion with the chair, but also with the keynote speakers, we have come out with the following two statements, which I would like to show now. Oh, yes, I can read it here. First one, the current drive for universal health coverage in low and middle income countries is going at the expense of resources for and attention to disease control programs. Could be something, a statement that may inspire you in the debates following the presentation by Professor Virasakdi. And the second statement, it's an illusion to think that disease control programs can strengthen health systems beyond selective aspects. Good. Now, we'll project them later again when we start the discussion. Now, we also have restructured a little bit the session in the sense that we are not going to start with the keynote speaker, but we're going to end with the keynote. And by doing so, the keynote speaker can somehow pick up some of the issues that have come out of the presentations and integrate it in his own presentation. Altogether, there are 7 presentations that have been accepted for the session this morning and that will be made. We grouped them in 2 categories. There's a first series of 3 presentations that focus more on the interface between programs and health services and systems, but from a more conceptual and theoretical perspective. And there's another series of 4 presentations that are more operational and that focus more on the interface of programs with the community and patients. So we're going to start, the session is so divided in two parts. We're going to start with the first series of 3 presentations, which will then be followed by Bruno Marchal's keynote, and then we'll open up the debate. We'll have then the coffee break, and after the coffee break, my colleague, Dr. Krishna, is going to take over for the second series of presentation and the second keynote speaker. Okay? Good. Having said this, let me invite the first speaker. The first speaker is Dr. Rahman from Bangladesh. He obtained his MBBS from the Dhaka Medical College, and he has been working in the very notorious BRAC institution. And he's going to give a presentation on unmet needs of health system for tackling neglected tropical diseases in Bangladesh. Dr. Rahman, the rules of the game are roughly 10 minutes for your presentation, so that we still have a couple of minutes for discussions afterwards. Please, the floor is yours.
Dr. Mohammad Shajidur Rahman Shaon, and I'm going to discuss today about unmet needs of health system for tackling neglected tropical diseases in Bangladesh. So just before going to my presentation and the scenario of Bangladesh health system and neglected tropical disease, I'm just a glimpse of introduction about neglected tropical diseases. Like, these are a cluster of chronic disabling infections affecting the poor and underprivileged population in low to middle income countries, especially those countries who are in tropical and subtropical region like India, Bangladesh, Nepal, and sub-Saharan African countries. They contribute, it contributes to poverty cycle, disruption in social stability, and further economic progress. They have received a little attention from the donors, policymakers, and public health professionals because of 2 reasons, I think. First of all, the big 3 infections all around the world: TB, HIV/AIDS, and malaria. And the second one, the neglected tropical diseases affects those portion of the population who have very low political voice. And WHO has stated that neglected tropical diseases are a symptom of poverty and disadvantage. So now we are looking at about the neglected tropical disease scenario in Bangladesh. In Bangladesh, malaria is endemic in 13 districts, and they are mostly situated around the Indian and Myanmar border. The annual incidence is 70,000 to 80,000, while the death is 300 to 700 per year. About lymphatic filariasis, it's been endemic in 34 districts, and most of the districts in north and northern west part of the country, and 70 million population are at risk of getting lymphatic filariasis. Then the diarrheal disease, it's very much common, prevalent, and highly prevalent all over the country, but recent trend shows that reported cases and case fatalities are in reduction. Kalajjar is endemic in 45 districts. The incidence in 2011 was 3,500, and death rate was 10% among the cases. Dengue has been found in all the 6 divisional headquarters, and more cases are reported every year. And soil-transmitted helminthiasis has been distributed all over the country, and it's due to low sanitation and hygiene practice. And Bangladesh government has introduced a national control program on malaria, Kalajjar, dengue, filariasis, diarrheal disease, and soil-transmitted helminthiasis. Among those, Kalajjar, filariasis, and soil-transmitted helminthiasis are elimination program. And it is to mention that Bangladesh has achieved national level elimination for leprosy from 2008, and now it's targeting towards subnational, district level elimination for leprosy. So before going to the health system, these are very, WHO has suggested 6 building blocks for health system, where the blocks are service delivery, health workforce, health information system, medical products, which include drugs and diagnostic tools and vaccines, health financing, and lastly, leadership and governance. And these all together with full access, coverage, quality management, and patient safety will lead to improved health outcome, increased responsiveness of the health system, and better risk protection, and overall improved efficiency of the health system. So now we are going to, I'm going to describe the gap in this service delivery system in context of Bangladesh. In Bangladesh, the service delivery is too much skewed towards the MDGs like maternal mortality ratio and infant mortality rate. And there are vertical programs, special disease control programs, which lacks integration at all the levels from primary to tertiary. And there has been a weak primary healthcare with lack of gatekeeping and effective referral system. We all know that healthcare system should be, primary, secondary, tertiary, and it should be in a pyramid shape. But due to effective gatekeeping and people's perception that primary healthcare doesn't provide quality healthcare, there has been overcrowding in the secondary and tertiary level, so which hampers the overall the quality of the services. And inadequate community sensitization and mobilization. Bangladesh has achieved a good success in case of TB control, and it has been possible. One of the main reasons is good community sensitization and mobilization, which in other neglected, for other neglected diseases has not been done quite well. In case of health workforce, the first problem is there is very low rural retention of health professionals, especially the doctors. So, and inadequate capacity building and refreshers training, especially in terms of community health workers. They are not getting proper training to address these neglected diseases. And this is, I'm just going to show a picture of Upajala Health Complex I have visited a few months ago. If your vision is sharp enough, you can see that the amount of dust over the table, it's so thick that it indicates for how many months he or she, the corresponding doctor, was not present in the center. So in case of health information system, Bangladesh has a very weak surveillance system with gross underreporting, which affects the validity and accuracy of the data. And there is also poor documentation and management that fails to guide the policy makers for developing adaptive strategies for these diseases. And NGOs and private sectors have been excluded from the health information system till now, so it should be included. In medical products, there are interrupted provision of priority drugs like for MDA or for miltefosine, and lack of pharmacovigilance and data on adverse reaction, and overall poor compliance by the patients. And in health financing, in Bangladesh there is no risk pooling mechanism like community health insurance or tax-based insurance program currently for the community people, which leads them to pay a high out-of-pocket payment for healthcare. And recent studies show that almost 64 to 68% out-of-pocket expenditure has been done for healthcare. And in case of leadership, there is a lack of sustained political commitment, and Bangladesh Ministry of Health and Family Welfare has adopted 3 sector-wide programs, namely HPSP, Health Population Sector Program, then HPNSP, Health Population Nutrition Sector Program, and lastly, from 2011 for 2016, it's HPNSDP, Health Nutrition Population Development Sector Program. And in all these sector-wide programs, there is no operational plan. There are 32 operational plans in HPNSDP, but no separate operational plan for neglected diseases or disease control program. So the way forward, I'm just giving some food for thoughts and debate. Like at first, okay, we should control the neglected tropical disease through extensive WASH program in the community, then integrated vector control program and behavioral change communication program. Demand side financing would be a solution as it affects, these diseases affects mostly the rural and poor people and ultra poor people. So Bangladesh has been very successful in promoting demand side financing in case of maternal mortality. So it can be, implemented in case of neglected tropical diseases. There should be a integrated disease surveillance program. And as already stated by our co-chair, that universal health coverage, probably it would be an answer to these neglected diseases, where we have coverage, we have the comprehensive services and risk pooling mechanism. So I think there would be a good debate on this. And last but not the least, we need more and more implementation research, more and more randomized control trials to make evidence and to implement this evidence into practice. So these are acknowledgements from James Brigand School of Public Health, where I work, and then from ICDDRB and DG Health Service for their cooperation and support. And thank you for your patient hearing.
Dr. Rahman, for your presentation of a number of gaps in the Bangladesh health systems along the lines of the 6 building blocks of, as defined by WHO. We can take some 5 minutes for reactions and questions to Dr. Rahman's presentation. Yes, Dr. Rahman, please comment. Stay with us for the discussion.
Thank you so much, Mr. Rahman. You have briefed the Bangladesh control programs very systematically, what is going on. And my question is, currently regarding the vector control programs, especially the control of lymphatic filariasis and malaria and dengue, chikungunya, all these control programs, what is the present ongoing reporting systems to the periphery to the center?
Okay. On the reporting system, Bangladesh has already implemented DHS2, and up to the Upazila level, it's in written form, filled by the community health workers, and they are all compiled in the Upazila health complex at Upazila level and then sent to the district and national level. But you have raised a very important question, like if you see the form the community health workers are filling, there are no provision of chikungunya and other neglected diseases to be filled.
The thing is, you told me the dengue is in only 3 districts or in the central?
Dengue has been seen in all the 6 divisional headquarters.
In those 6 divisional headquarters, are they communicating immediately the dengue reporting system?
No, most, the 6 divisional headquarters, and it mostly the dengue affects the affluent society, so they are, most of them are going to the private hospitals, and they are not being reported, and that's why I haven't shown any statistics for dengue.
Okay.
It's very much underreported.
Thank you. Any other reaction or question from the floor? Yes, in the back. I see two ladies.
Yes,
Go ahead,
thank you.
Karina.
Karina from Indonesia. Just want to react on the present of the way forward. When you are speaking that to have integrated the NTD program to the whole health system, there are 3 priorities that you are talking about. That you embedded the WASH program, the vector control program, and BCC program. You know, in developing world countries, we always thought that this one should be goes together, integrated, right? But the problem is when we do implementations, then as much as we want three programs runs together, we need to think which one is more priority to do first. Because if not, then you do 3 programs but very superficially, and it's not leading to the target we wanted. So according to you, from the 3 programs, which should come first in Bangladesh to tackle this program?
Thank you.
Secondly, to integrate the disease surveillance systems, you need to sit down together at the national level and then to decide which key indicator, because you know ego sector, then every disease program wants a lot of indicators to be taken to the integrated system, surveillance system, and it's become a very big surveillance system, and then it will burden the facility level when they report it. So,
okay.
Yeah,
thank you.
Thank you.
Okay, to answer your first question, I think in resource-poor settings like Bangladesh and other South Asian countries, we are doing vertical programs where there is reduplication of services. So then you have asked me about which come first, the BCC program or the vector control program or WASH program. I think they should be merged together and integrated, well integrated, so that we do not reduplicate services. And that's, waste of our resources also. And I think it should be together. It should be together. No coming first or last. And about the disease surveillance, what you have raised, that people, the different programs are having different indicators. So for these diseases, I think there might be a group of indicators altogether. So, for country statistics and for neglected diseases, where we can have a look overall, diseases, not specific diseases and specific indicators, one for TB, one for, one group of indicators for TB, one group of indicators for malaria and other diseases. Okay. There should be, the indicators might be also combined if the system is combined together and integrated.
Okay, thank you. I'll take a last short one. Melissa, please.
Yeah, I was just thinking about the broader context of your talk and wondering, I don't know if you know this, but what proportion of Bangladesh's budget comes from external...
we can't hear you very well. There's a problem with the mic there.
Sorry, I'll start again.
Okay, please speak up.
I was just thinking of the broader context of your talk and wondering what proportion, if you know, of Bangladesh's budget comes from external donors, and how much influence you think colleagues in Bangladesh have over the setting of priorities and the way in which programs are implemented.
Okay. Clear question. The importance of external donors in the funding of the Bangladesh health system, and whether this influences decision making at the national level.
Yeah, Bangladesh health system decisions are quite influenced by the donors. So I think it should be, the priorities should be taken sitting together with the donors and the policymakers and other stakeholders in the same table to have an integrated one, and to set future goal for disease control program. And donors obviously play an important role here.
Okay. Thank you. Thank you very much, Dr. Rahman. May I invite Dr. Preeta, please, to join us for the second presentation. Dr. Preeta is a Senior Research Fellow within the Public Health Foundation of India. She is working a lot on the subject of universal health coverage and is actually based now in Delhi at the Institute for Studies in Industrial Development. Dr. Preeta is going to give a presentation entitled Integration and Adapting Human Resources at Service Delivery Level with National Disease Control Programs. Preeta, please.
Good morning. So with the 10 minutes that we have here, I'm going to run through a case study. I would like to pull your attention towards the vertical disease control programs that we have in India, and also how different states are coming about with integration in their own ingenious ways. So this case study is mainly looking into just one part of the health cadre, an allied health professional group called lab technicians. Laboratory technicians are very much understudied, and we came across certain very good observations in our research, mainly looking into how different states are involving laboratory technicians and trying to conserve their resources using strategies like multitasking, multi-skilling, and also task shifting. So this is a part of a greater study at Public Health Foundation of India, where we're looking into different pathways for integrating disease control programs. This is more like solutions and strategies for the states to implement integration. And I'd like to acknowledge my team and PHFI for making this possible. And as a part of our data collection, we actually interviewed almost 97 or more program implementers, policymakers, people from the civil societies, policy influencers, as well as academia from 6 different states in India, as well as from the center. And what we came across was a certain amount of innovations by the state governments in trying to conserve a very small part, like trying to conserve the resources and also trying to integrate, bring different programs together to meet the health needs of the population. We saw here was multitasking and multi-skilling. So with a lot more, we probed further with certain interviews and repeated interviews. We went back to our respondents. Thanks to their feedback, we actually coming up with this case study, this understanding of how 3 states, mainly Kerala, Gujarat, and Tamil Nadu is now in the process of rolling it out, how they went about integrating disease control programs. To give you a backbone, to give you an idea of laboratory technicians, I'm just running through this for those who are not familiar with the disease control programs in India. They are the backbone of various programs, as some of our respondents from Gujarat themselves have told us that for NVBDCP, they are the crucial elements. And then not just a minority when it comes to health cadre, because unlike ASHAs and ANMs, they're also heavily, there are a huge number. For example, in the case of Kerala, NVDPC, National Vector-Borne Disease Control Program, they place almost 30% of all lab technicians within the health system. So vertical programs are actually recruiting and paying and supporting for lab technicians to work for their programs. They're placed at PHCs, CHCs, ICTC centers. So it's not just the district, but also at the peripheral level. And they science high school graduates with certificate courses in MLT, and programs like NACP are asking for higher qualifications when recruiting for lab technicians. And it's also interesting to note in the far right column that actually they're also remunerated differently. Different programs give different salaries for lab technicians, and they made to do the same task again and again and again. So there's not much diversity in the kind of diagnostic tests they do for their respective programs. What we found in Tamil Nadu was there was a 24/7 PHC, and they had 3 lab technicians placed by the general health system, by NVBDCP, as well as RNTCP, and they're just focusing on their own program and nothing else. The model of integration that we found in states of Kerala, Gujarat, is that lab technicians, those placed by NVBDCP, RNTCP, if you look into the first row there, they are given additional tasks. So they're given additional task of working not only just for their programs, but also for a routine diagnostic load that comes to the facility, as well as other state implementation, state programs, like the newborn screening programs. So in a way, these vertical programs are actually supporting the general health system in a diagnostic support. But this is not a one-way process. Actually, the general health system is also supporting these vertical programs in diagnostic support, in the sense the lab technicians placed by the DHS, as well as those in the medical colleges, are supporting the vertical programs like RNTCP and NACP for their diagnostic facilities. So in a way, it's a two-way process where they're helping each other out and they're improving the coverage of not only the vertical programs, but also the general health system. The last model that I want to focus on is, again, where there's an NCD pilot project in Tamil Nadu, and they have actually placed nurse practitioners to work for the NCD program at various facilities. And these nurse practitioners are also skilled, are also trained, and they take up lab technicians' role in facilities that do not have lab technicians. So how did these states come about? Why did they go about doing this? So the rationale that the policymakers at the state levels, they gave is, of course, it increases access to cheap or affordable diagnostic facilities at the grassroots, say the CHC or the PHC. Not only for the vertical programs, but also for other programs that the state runs. And in addition to that, though we are moving towards the idea of universal health coverage, please note this point, we are going towards universal health coverage by actually increasing their access because of these integrative strategies that we're doing. And also the health needs of the people. So as Dr. Rahman had told us earlier, it's the same in India also, where the center has certain amount of priorities, more focus on the Millennium Development Goals, and more towards RCH, RNTCP, NACP, whereas in the states, actually they don't match. The state priorities may be different. The disease burden of TB or HIV/AIDS must be not that crucial in many districts in the states. So for that places, in that areas, what exactly do the states do? Because the resources that's coming from the center is not skewed, it's not matching with their needs. So they come up with certain jugaad or strategies where actually they're asking people to work across programs and give their support in both directions. Now, where does this kind of assertion of the state come from? So India is highly heterogeneous. Every state has its own level of resources, its own governance structure, its own political specialities. They're all different. But states as such are becoming more and more assertive in telling that, look, this is our priorities, this is what we need, and we need this kind of a support from the center. And this is not just coming in a day or two or because of some politician sitting in the state, but also you can see slowly that there's this decreased central and foreign funding for many of the health programs in the states, and that states are left to fend for themselves or meet these program objectives with their own resources. So when they face their own resource crunch, they actually have to get assertive. They have to come up with innovative strategies. And it's not that they're waiting for the center to come with the solutions. They are creating their own pilot models. And it's just not the southern states or what the so-called progressive states, but even states from the Northeast and Bihar, they're coming up with solutions and they're suggesting it to center that, okay, this is how we can come about solving the problem, human resource crunch and many other areas. And this actually is, influences the center to come up with certain directives, certain strategies for integration. And you can see the state governance, which is more responsive, they implement it faster, while others would take maybe 1 or 2 years more to implement it. And another thing about the administrative structure in the state itself that helps in certain kind of integration is that when you have a common director of public health, to whom all the vertical disease control programs, all the NCD programs, as well as other state programs report to. So you have a common administrative head, even if the finance is coming from different sources. So this person, he himself admitted that he had less number of collaborative partners to convince. So it was easy for him to roll out certain integrative strategies, and he himself admitted that programs that do not report to him, especially things like NACP, he finds it more difficult to bring in their resources or support them either. And the last point, the second last point that, the major point that comes out is lab technicians, they themselves have said that when they were involved in mass drug administration campaigns or pulse polio campaigns, or when they were going through certain disasters, disaster management programs and all. So in these conditions, these lab technicians had to work with other programs. So when all the manpower from different vertical programs work towards a common goal, actually it builds, it cements some kind of a professional relationships with their colleagues in other programs. At the same time, it builds a professional relationship with their supervisors from different programs. So that kind of a work atmosphere is created, and that actually helps when you bring about certain amount of resource pooling in terms of health system structure. Now, the barriers you can find here is that there's a lot of turf control, especially from policymakers at the center, where they say we cannot spend our resources, we do not want to share our resources or give it away. And there's also a fear that they lose the technical expertise. Because you see, these lab technicians, when they're recruited, they just graduates with a one-year course. But it's a lot of intense technical training that these programs put into them, and they fear that they might lose out on that advantage, that that kind of investment is not paying out. And there's also experience of leprosy control program where actually they have seen the technical resource, like losing technical expertise quickly when they go for diversification. And another reason that we also came to understand is maybe because they do not see the opportunity that comes when you go for an integrated thing. What other programs or the other system can support you in your own program objectives. And again, operationalization has other issues, mainly because every program has its own different structures, different cycles, and that goes against creating a common integrated management structure. Certain challenges, and I'd like to stress more on solutions for that, because though the states themselves have faced problems in this change management, but they themselves have also come up with solutions for that, strategies for that, something which other states can actually learn from. So what they said that when these lab technicians were made to work across, the lab technicians themselves had an increased workload, and there wasn't an increase in trained manpower. In the sense, there was not additional placement of lab technicians to help them out. And interestingly, people from the civil society have come up with the solution of looking for time motion analysis or assessment, where you look into the diagnostic load that comes into a system, that comes into a PHC, and then based on the diagnostic load, based on the disease burden that's coming into that place, you look into the time needed, the man hours needed, and based on that, you place your manpower. And it always happens the other way around in our Indian health system. So that kind of use of management principles or HR principles in health system is the need of the hour when it comes to planning for workforce. There's also some amount of task shifting, because diagnostics, you have the highly skilled, technically skilled diagnostic procedures, and some which can be done by other staff, like the pharmacist also. So a little bit of that could be shared by other allied health professionals also. And because the lab technicians, another major problem they say is they have multiple command lines where they have multiple bosses to answer to. And these multiple bosses, they do not talk to each other, and they put their own targets, and which is kind of unrealistic, difficult for the lab technician to fulfill. And it compromises on their quality and also their life. Some people have also observed, like they've reported that they stay back up to 7 o'clock at night just to finish up their work, their targets, and they can't stay back longer because they have to catch the last bus home. So what we need is an integrated monitoring system, an integrated guideline where the supervisors also acknowledge each other's program objectives and work towards a common goal. And of course, we need to look into the remuneration and career prospects also before we go for any kind of change in this regard. So I'd like to stop here, and I think we're running out of time. I'd also like to thank ITM and IPH for giving us this venue to share. There's a lot of more work to be done, especially when it comes to human resource planning. And I think this is just the beginning that we're having.
Okay. Stay with us for a couple of minutes. I can still take one or two questions, reactions. Marleen?
Thank you for most fascinating talk, because you are right. The laboratories are platforms that that's where everything comes together, and that is at national level, but at very local level. So I enjoyed your talk, and it reminds me of, I would like to make the link with what Professor Jacob John said. You need a systems view, and because there would be no company allowing, a private company allowing such a waste of resources. If it would be a car company, they would not allow for such inefficient allocation of resources. So the system you are proposing is much more efficient and sustainable. Yeah? So that's where we can learn from the private sector, I think. Now, I want to share an experience in the context of Kala Azar control, a story I was told at one of the advisory committees. One solution that was put forward to solve the human resource problem was contracting out of laboratory services to the private sector. And would like to hear your comments about that, because, well, the reason why I know it is because, yeah, no, just as an anecdote, I wanted to share to what extreme situations this led, because in Kala-Azar we have a rapid diagnostic test, okay? So that is a test, that is a strip test that can be read after 10 minutes at point of care. So what happened was that because of the contracting out scheme, the sample would be taken at PHC level, and then it would have to be sent to Patna, because of the contracting arrangement, so to the private lab that would do the rapid test, and the result would be sent back then after 10 days, 2 weeks, to the PHC. Now this is maybe an extreme example of what this arrangement led to in this particular situation. So, which of course it's foregoes the whole point of a rapid diagnostic test and decentralizing access to care to the periphery. But it's also again a symptom of a lack of a system view. What are we doing in fact? So, but on a general level, maybe you have some comments about this contracting out. Do you think that is a solution or not, and why not?
Okay, thank you, Marleen. Dr. Prita, would you like to react to that?
Yes, so the major problem that you faced was actually lack of facilities and manpower crunch. And when it comes to contracting out, why did it have to go all the way to Patna? I mean, in another way, because decisions are made at the state or at a higher level, they go for these kind of skewed thing. But had the local people or the local medical officers or the local governance, people's representative, if they had some amount of say in this, wouldn't they come up with a better solution? A faster solution, actually. And so what I see in Kerala and other southern states also is that the people's representative groups, the panchayats, they are also supporting the vertical programs in many ways by giving them support in terms of placing laboratory technicians or other kind of equipment support. So if I get your thing correctly, contracting out is a good thing, but if the decision is given to the local or decentralized planning, if the people at the district level, I think they'll come up with better solutions.
Okay, thank you. Professor Virasak, you wanted to react to that quickly?
Just one quick question you may want or may not want to answer. I think your studies mainly look at the provider sides. What about from the perspective of the client sides? Is the service improved or worse? For example, do they have a one-stop service for everything in the indication fashion, but is the system delays reduced? This is
okay. Yes, so there is a quote that actually I didn't put it in the slide. But when we ask certain people, the people who come to the PHC, so what they're telling is they're very happy that this PHC in their village is having all services, RNTCP as well as for non-communicable diseases, because if their PHC didn't have that, they'll have to go to a private sector place which is going to give them, they'll have to shell out more, or else they'll have to spend almost another day traveling to the nearest facility, which is again, they'll have to shell out more. So they're saving up on a lot of time and money, and though we didn't focus much on the client side, but we did get some certain good reviews about this kind of an arrangement.
Okay, thank you very much. Thank you, Dr. Prida. May I invite the third speaker in this morning session, Julie Balen, lecturer at the University of Sheffield in the United Kingdom, who has obtained a PhD in public health and epidemiology from the University of Queensland in Australia, has been working a lot on schistosomiasis and other entities in Asia, and now more working in the West African setting, if I understood well, on health systems. Julie is going to give a presentation entitled Vertical, Horizontal, Diagonal, the policy debate continues, but where is the evidence? Julie, please, the floor is yours.
Thank you. I think that was my handwriting. It's actually not immunology. I'm not an immunologist, but epidemiology. But just to clarify. But thank you.
Did I say immunology?
I think it's my handwriting. Just in case someone asks me some tricky immunology questions, I won't know the answer. So I'm going to start with a small disclaimer, I'm afraid, and that's that it's very challenging to talk about complex topics and issues such as these in 10 minutes. So by definition, I'm actually presenting a selected and fairly simplified small piece of a much larger and richer set of study results and ideas. So today I'd like to present some work that we did on the interface between vertical disease control programs and horizontal health systems. And this work, though it's unrelated to my last talk, it follows on from it in some way, as I naturally began to think about how these two disparate entities interact, if they do so at all, and what are the outcomes of such interactions. So by now, so I'm sure you all know the backdrop of this story. The Millennium Declaration and its 8 Millennium Development Goals for Sustainable Poverty Reduction were instrumental in shaping global health policy over the past decade. Together, they provided a platform and a basis for large-scale donor support from both public and private sources, and leading to proliferation of global health initiatives, with marked increases in funding to low and middle-income countries. And these global health initiatives predominantly finance large-scale or national public health programs for the big three, the HIV/AIDS, tuberculosis, and malaria, as well as sometimes those aimed at improving reproductive health and childhood immunization. But some have also described this as an era of AIDS exceptionalism, where vast amounts of resources were poured into the control of HIV, perhaps at the expense of other health conditions. And there have been times where various health systems were actually unable to respond to this in a balanced and coherent way. And increased attention is now being directed towards health system strengthening. And there was, or perhaps actually still is, a growing interest in the integration of vertically driven programs into horizontal health systems. And though a few studies have reported both positive and negative impacts of integration, I think it's still the case that there is a gap in meaningful and robust analyses in this area. So we set out to explore how 5 selected priority health programs listed here interact and influence each other, and how they interact and how each of them interacts and influences the core health system. And this was very much a positive policy analysis with the aim of finding out what is happening on the ground, who and what are the drivers, and what can we learn from it in order to ensure that the policies in place do actually work. And we did this by examining 544 published and unpublished documents, and I conducted a total of 41 semi-structured key informant interviews using purposive sampling across national, district, and village level settings in the Kingdom of Cambodia. I unfortunately don't speak any Khmer, but like when I was in China, I worked very closely with the same translator throughout the entire data collection and analysis process. So before I continue, it's important for me to say that this work is a critique based on primary and secondary data, but it's not a criticism of global health initiatives. Their role is instrumental in improving health outcomes, but there may be other ways in which they can be even more effective than at present. And so the way we did this was by using the systematic rapid analysis framework shown here. Though for simplicity, I've only shown 2 out of the 5 control programs that we evaluated. And we focused on any cross-program and program system interactions. We took a very functionalist approach to what makes up a health system, and this is something that we can certainly debate and discuss later on. But with this functionalist approach, we collected and analyzed the data according to 6 key functions, namely stewardship and governance, financing, planning, service delivery, monitoring and evaluation, and generating demand for services among the public. These are somewhat different to the dominant WHO 6 building blocks, but they're actually very much related. Now, we've spoken a lot during these days about theory versus practice or policy versus implementation, if you want. And in reality, public health programs are rarely simply fully integrated or completely non-integrated. So we therefore estimated the level of integration according to a 4-point gradient on a scale from no formal interaction at all the way through to full formal integration, shown here. For those who were asking about measuring a few days ago, I'd say this is a form of measuring, or documenting, perhaps is a better word, though some actually prefer to call it guesstimating. It's not precise, there were no p-values or confidence intervals, but it was a way of trying to understand the level or the strength of integration, though according to a somewhat artificial scale. So what follows are some visual representations of a few key findings. I hope it's clear, actually. It's not so clear on the... Is it possible to have some slightly different lighting on the slides?
Could we reduce a bit the light, please?
This one. Sorry. Thank you.
Okay.
So each of these points represents a control program, the 5 control programs that we evaluated. And the central blue shape, I hope you can see it, maybe it's a little bit easier on this one, represents this health system. And the bigger the system shape, the more integrated the programs are within it. Whilst the thicker each of these lines, the more linked or integrated each of the specific programs that the lines connect are. So in the case of stewardship and governance, shown here, and this included the regulatory and accountability frameworks and the annual policy formulation for the national programs and the overall health system, there was very little integration. Although in theory, according to the Ministry of Health organizational chart, the agencies responsible for the programs are subordinate to the central directories of the Ministry of Health, in practice, the national programs are actually governed quite separately, with almost vertical stewardship systems, and on a daily basis they were managed with little input or interference from the Ministry of Health. This was true for all programs, but it was most notable for HIV program, which also had its own parallel strategy setting, planning and monitoring processes. There were some stronger cross-program linkages, in particular between maternal and child health and immunization, and between HIV and TB, as well as a formal link growing between HIV and maternal child health through something called the Linked Response for Prevention of Mother-to-Child Transmission of HIV. Now, I don't have time to go into that, unfortunately, in detail, but I will mention that it's an integration reform which has actually been championed by key stakeholders within the HIV program, and it's being driven by donor funding, which is streamed through the HIV program. At subnational level, or the operational district in Cambodia, there was a higher degree of integration into the health system, and programs had a lesser degree of autonomy than at national level. But that's just stewardship and governance. When we move to financing, for example, compared to disease burden, the HIV program had the most generous amounts of financing than all the other programs, and only 3% of its total budget stemmed from government funds. This has, well, I won't say resulted in, but certainly it's enabled an increased power base and a more centralized position for HIV among other stakeholders. And this power, influence, and key positionality played out to make the HIV program the most linked to all the other programs, although it showed very limited linkage and integration with the overall health system. And again, there's some variation between national and district level. And several respondents actually expressed concern for this, that this model is creating a parallel health system. And this is particularly in light of the desires expressed openly by key HIV stakeholders during our interview to keep forming links with other programs and in order to, I quote, close the circle. So I don't have time to go into details on the other functions at national or district level, or for any of the functions at local village or health center level. But I will mention that at local level, the scarcity in human resources meant that a handful of staff, like Pritha just mentioned for India, they end up doing a lot of cross-program integrated multitasking. So there is evidence of linkages and some degree of integration, but the links were not formed as a result of systematic or explicitly strategic evidence-informed processes, but instead they seem to have emerged quite ad hoc. And they have been driven by financing and power differentials through certain programs as a result, and as a result they focus on specific programmatic imperatives rather than on broader health system needs. And one of the key informants summarized, oops, sorry, I've gone too fast. One of the key informants summarized concerns nicely with the following quote. There are multiple systems in operation right now, which has had a somewhat destabilizing effect on the core health system. So this left me wondering, is this integration a case of health system strengthening or health system weakening? In drawing some more general conclusions from the work, and this is my last but one slide, the success of integration reforms depends upon and is influenced by many interrelated factors, including operational, technical, and political factors, such as what Pritha referred to as turf control. In fact, a couple of our key informants mentioned the three key barriers, like the 3 L's: loss of face, loss of benefit, and loss of power. And another informant quoted a Khmer proverb, which is, "You cannot have 2 tigers in the forest." So this is just a sort of summary slide, but all I want to really highlight is that integration is not an apolitical or technical notion, as many public health experts may claim. Global politics and policies are influencing these local relationships between stakeholders and between programs and systems. But at the same time, the internal power dynamics are also significantly shaping and contorting decision-making within the Cambodian health sector. And this is exacerbated through the availability of specific donor funds. And as global funds are linked to global health objectives, national and local health challenges within Cambodia have become overshadowed by dominant themes in the global arena, significantly distorting domestic priorities. So it's in fact very difficult to tie local planning cycles with global policies. I think this calls for the gathering of deep contextual understanding of the dynamic and complex political nature of recipient governments' health systems, and a serious rethink on the potential participatory political processes that are involved in giving and receiving of aid. I think we sometimes forget that there's plenty of politics in national health systems, and understanding the messy reality of health systems requires an understanding of local power and politics. Now, I'd like to quote, just before ending, a paper that is actually 13 years old. It's a paper by Sarah Atkinson and colleagues on incorporating local social organization and political culture into health research. And I quote, "Increasingly, the influence of these factors is acknowledged, but we do not really know what to do with this observation in practical terms. The result is a schism in the literature. On the one hand, there is a social scientist illuminating local politics in all its fascinating detail, but with little indication for practice. On the other hand, the health system researcher focuses on the mutable and manageable aspects of healthcare, whilst acknowledging political aspects, sometimes with evident frustration, ultimately leaving these to one side as something that is not amenable to change from the health sector." End of quote. Although it's an old, now 13 years old paper, I think it still holds a grain of truth, though I do feel relieved and optimistic at events such as this one and the debates and discussions we've had over the past days. So I'd like to make one final point about the nature of health systems. And when we talk about health system strengthening reforms, we still look for templates to cut and paste, I think. But as I try to show with my many visual diagrams, there's no one version of a health system. There are many versions of various interpretations of parts of health systems operating in dynamic ways and as experienced by different actors occupying a range of spatio-temporal settings. So I think we need to first accept this pluralism and dynamic contextualization and then explicitly move beyond by incorporating relational aspects into our actions in order to build more resilient and equitable health systems. Okay. Thank you.
Thank you very much, Truly. I'm looking at time. We are a little bit behind program, so I'll take one reaction, one question before giving the floor to Bruno.
I will be very short. I would like to thank you and congratulate you, because what I learned is a new visual tool that simplifies the description of the integration problem in a...
Can you speak
Sorry,
up? We can't hear you well.
Can't you hear me? Now. Okay, I'll be very short. I just want to congratulate and thank you. The thanking part is about the tool that you provided us with in order to visualize the relationships between programs and systems. And I think this is a very handy thing to do. Thank you very much.
Okay. Thank you.
Thank you for this indeed short reaction. I propose we keep it here and now go to Bruno for his keynote. Bruno, please.
Okay. So what I'll do now is kind of take a step back. We had these 3 presentations now. And if you look at this first paragraph, which was taken from the rationale or the introduction of the colloquium, I think if you need to talk about these interfaces between programs and systems, and if all these words are so different, actually we may need to think about frames or ways of thinking about these concepts. And so what I'll do is actually look at health systems strengthening, move on to the interface between programs and health systems, and then local health systems strengthening. Now, a health hazard warning. This is a bit of a stream of conscious presentation. You have some motilium on your tables. If it becomes too much, one pill, it will help things. Right. So health systems are back on the agenda. It has already been talked about in previous presentations. What was perhaps not mentioned was that World Health Report 2000 also really kicked off this discussion, besides, of course, the big initiatives, the 3x5 initiative of UNAIDS that wanted to put 5 million of HIV/AIDS patients on treatment by 2003. The performance of the global health initiatives, and in fact it was Gavi perhaps that kind of coined this phrase, weak health systems present bottlenecks. Then we had the whole evaluation of the progress to MDGs. We started realizing that we need strong health systems to reach 3, 4, and 5. The universal health coverage movement calls for health system strengthening. And I think the thing which was announced just recently, this global investment framework for women's and children's health, I would not be surprised if in typically 5 years from now they start realizing, yes, we need also strong health systems. So these have been calls for health system strengthening, therefore, which were initiated by a lot of these global health initiatives and global health actors, but with quite some apprehension, because, and this is actually from a paper by Hafner and Schiffman, who tried to figure out how health systems and health system strengthening came back on the agenda, the global agenda. And so they did an interview with people from boards of these big global health initiatives, and this is from the Global Fund. And they said, you know, really, health system strengthening, if you move into that thing, it's going to be a big hole. It's as if health systems are considered as black stars, kind of absorbing everything and everybody. in their unfathomable depths. So if that's a kind of outlook, then of course I think it explains, I think, in my mind, a bit why these different kinds of health system strengthening windows that were developed by the Global Fund, by Gavi, by PEPFAR, and then also the Unified Health Systems Funding Platform in 2009 by these actors, why I don't see so much evidence that it really works, I think. I'm not sure if what they do is really so effective. Anyway, to me and to a lot of people, I think also in the department, this raised quite some questions. One, do these global health initiatives really strengthen health systems? Two, what is happening at this interface between the global health programs and local health systems? And I think we can here change word vertical program by policy, by global health intervention. I think anything that falls on the neck of people who are at operational level is something that is going to be troublesome for them. And then three, okay, if we have all these programs, and if they do some health system strengthening, do they really strengthen local health systems? And so this will be kind of the three questions which I'll use throughout the rest of the presentation to structure things a bit. Because at the end, what we really need here is much better analytical frameworks, much better ways of thinking about these things. And what you quite often see in the literature is that studies looking at these questions basically are descriptive in nature. They describe things on the ground, but they don't really explain things. And very few of them actually start from a hypothesis or from a way of what a health system should do and how a program should interact with local health systems. And so in Antwerp, I think, if I look back over the last 10 years, we've been working on these three questions in a non-systematic way. But I think there's a bit of a red line coming out of that work slowly. So, health system strengthening by global actors. That was our first point of attention when, because I should in fact say something else. There was this primary healthcare movement which kind of was relaunched also from the 2000s onwards, and that was another driver of pulling attention to stronger health systems. And so when 2008 came up and the 30th anniversary of the Alma-Ata Declaration, we started looking at that primary healthcare thing, and among those discussions, one of the things that was triggered was, well, these global health system people, the global actors, do they really strengthen health systems? So we did a bit of a literature review at that stage, and what we basically found was that a lot of the programs and policies and strategies proclaimed by these big actors are quite selective in nature. They strengthen health systems, or they aim to strengthen health systems, but what they basically do is focus their attention very much on selective parts of the health system, so that their objectives can be reached. And okay, no problem with that. I think it's sound management. But then you should perhaps not claim to really strengthen health systems in a comprehensive way. This was followed up by some field work by a number of colleagues actually here in the room who went and looked at the interface between mass drug administration campaigns for neglected tropical diseases in Mali. And one of their conclusions was that, okay, you can have these positive synergies, but they basically occur much easier if, in fact, it's not even a condition, in robust health systems and health services. And if you have disease-specific interventions that intervene in weak systems, well, there are kind of two reactions, of course. They can actually do no harm at all because there is no system that can be harmed, which is sometimes happening. But in other cases, they can actually make the services even more fragile and weaken their responsiveness. Now, in the next step, somehow, at some stage, it was Katja actually was asked to write a paper or to kind of prepare a paper for Acta Tropica, where they wanted to have a kind of a contrasting view or an analysis of the view of NTD-controlled programs on one side and the health systems perspective on the other side. And that was our main objective at that stage, to kind of figure out what are these different camps kind of saying about each other, and how do they see the interface between NTD programs and health services. And so, of course, we found some mentioning of both positive effects and negative effects of health services on the programs. Quite obviously, of course, if you start with the right-hand column, weak systems are not going to do much to strengthen vertical disease control programs. And on the other side, there was some evidence, but I think evidence is perhaps too much of a serious word for this. There were some anecdotes and some mentioning of positive effects of strong health systems on NTD control. Okay, case finding, personalized health education can be done better. Supervision and support will be better if there are strong systems. But there have been quite few studies that really documented this issue. We also found the opposite, of course, or kind of examined the opposite. That's to look at how the entity control programs could either strengthen local health systems or weaken them. And again, here, despite the fact that there is a lot of, well, at around that stage, also the Lancet published a paper on the positive synergies. I think we need to take that with a kind of a grain of salt. There's a lot of anecdotal evidence, again, but little very, very strong evidence. So what we see is, okay, NTD programs can actually improve the health information system, drug procurement systems, they can improve technical competences, and with a bit of luck, it will spill over into the general health services. On the other side, again, some anecdotal evidence, basically, on negative effects, and they were usually categorized in the sense of duplication, so instilling or initiating new parallel systems of reporting, for example. Effects of distortion, whereby health workforce distribution would be affected by programs, drawing away people from the general services to the programs, and also basically interruption of services if people were drawn out of health centers to do particular program activities. We won't spend much on that. There's a paper in a poster actually here that is looking at the same aspects in a different way perhaps, but I think kind of identifying the same issues. So basically, if you look at the kind of literature, both on health system strengthening and the literature on this interface between vertical and horizontal, there are quite a few frameworks to assess what's happening at that interface. And the initial assessments of some of these global health initiatives, like PEPFAR or the Gates Foundation, they found this kind of words. And again, you see there's quite little conceptualization behind it. You see exclusion of stakeholders from decision making, yes, no alignment, problems with fragmentation. It all makes sense, but why is this happening actually? And is there no other way to kind of think about these things? Despite the fact, in fact, that we have a lot of health system models. So it's not a lack of models. And this is just kind of a few of these models. Will be very hard to see on your slides, but you can get them in the reference list. At one stage, we looked at the evolution of the different kind of health systems that have been published. And basically what we noted was that from the year 2000 onwards, here, when the World Health Report 2000 was published, that's when much more health system models were developed. And these are just a few of the ones that came up. You may recognize here the control knobs framework by Roberts, which is used quite extensively in World Bank programs. And if you have a very sharp eye, this is ITM's Health Systems Dynamics model. Now, WHO's model is simple, but it's the one, of course, that started dominating, because of that, probably, the whole discourse. So this is the way the WHO presented the health system in its World Health Report 2000, saying that if you want to achieve health, you need actually to achieve two more objectives. That's health services and health systems that are responsive, and not only technically, medically, but also to other expectations of people. And you need to have a quite fair contribution of the users of the system to when they access and go into health services. To do that, the health system has four key functions. Of course, there's delivering of health services, the provision side, but there is also training and mobilization of infrastructure, of logistics and drugs. That's what they called at that stage, creating resources. Then there is financing, so setting up financing systems both for the whole health system as well as reimbursement systems within the system, which need to be fair. And the key thing they introduced at that stage was the notion of stewardship. Now, there's a lot of contention on that. Stewardship was not really a word that was used before in public health. It kind of went on the agenda, and quite quickly it disappeared again. And we'll definitely come back to that. What I would like to discuss here, or say at this stage, is that the stewardship function is an oversight function. It's a regulation function. It's a function that needs to ensure that public goods are run in the interest of the public. And if you don't use that notion, then I don't think we speak about stewardship. At that stage, we will talk about management and leadership and governance. But the key issue of the stewardship notion here is it's working for the public and protecting the public interest. Right, so plenty of models, and perhaps a simple one, in fact, which took over health systems strengthening world, because, as already was shown by Julius, and quite a number of people, in fact, I mean, almost all of the previous presentations, somehow used the 6 building blocks model. So WHO started now reshuffling things a bit, kind of keeping the overall goals, saying that we have 6 building blocks. And I don't know, if you look at this kind of figures, I see just one arrow. And I think it's a bit of a simplistic way of presenting health systems. And, okay, despite that kind of comment, It's the model that has been taken over by WHO. In 2007, they published their flagship report, World Health Report 2007, on health system strengthening. Well, okay, you don't see arrows, but at least they see, I mean, they've added arrows now between these different functions here. They also recognize in this figure that the stewardship role, or perhaps as they call it, the leadership and governance role, is central to the whole thing. And a few years later, they kind of used complexity thinking, or at least systems thinking, to look at health system strengthening. That's the Savigny and Adam paper. They represented it in this way. I don't know what you see as a difference, but they put community at the center of the whole thing. Now, we use this framework when we start another project looking at fee exemptions in West Africa and the influence of those policies on local decision makers at district and at hospital level to reshuffle it. So let's just take a look of how you can play around with building blocks. And I don't know if you, I mean, I was raised with Lego, you know, this Danish, very colorful building blocks. So when I look at this kind of things, then I think, okay, first let's put some other names and terms on that. Let's at least introduce the word stewardship here, and let's just refigure them. And so instead of going from a non-hierarchical and not systematically linked model of what health systems should be, I think we can actually look at health systems, definitely at the local health system level in this way. Because there is a central axis, of course, in a health system, and it starts with the stewardship function. The other thing which is quite important is to look at the different arrows between the systems, because it's about dynamics, it's about complex adaptive systems, basically. It's about connections, it's about interactions, it's about people working in the health system, working within each of these functions, who interact with each other and who do things. So that's a model we used in this FemHealth project. Let me give you a bit of an explanation or an example of how you can use that to map effects of policies or programs or global health initiatives on this local health system. As you see here in orange, that's kind of a pathway of a selective program. What they basically do is strengthen the input axis of the system so that specific activities of health providers and specific services are targeted and improved so that they hope in that way to improve also the targeted groups of the population. And well, let's take an example of introduction of a new vaccine. What that actually will do is try to cover in a much better way the health of infants and children. You want to modify behavior of practitioners. That means introducing a new modified immunization schedule. For that you do training, of course, and usually training of trainers and trainers of trainers of trainers. But you also provide the inputs on the left-hand side: budgets, vaccines, monitoring and reporting systems. Now, these are positive effects, or at least we can usually consider them to be positive, but of course you can also add all the negative effects which are very likely to occur if there's no coordination at that level. You can get displacement of routine services. You can get health workforce imbalances if you start introducing premiums and benefits and per diems and redistribution of staff. You can have duplication of work if you introduce parallel systems of reporting, of course. And the most important thing perhaps is that you can have quite some distortion of the local priorities, and that will affect priorities of health providers, but also of community, perhaps, and of the stewardship function. Now, from that, you can then start thinking about how can we actually strengthen health systems. And if you are in a local vertical program, or you're at the national level in a vertical program, perhaps the best strategy is the first one, is just to do no harm and make sure that you avoid a negative impact on the local health system. Now, if you're a bit more ambitious, then you go for the selective health system strengthening scenario. That's number one. Plus, really strengthening the program-specific capacities. And of course, the most difficult one, kind of the holy grail for us systems people, is the comprehensive health system strengthening. And that actually would require much more long-term investments and coordination between actors both at national and local level, on the basis of shared values, basically, and on a quite sound analysis of how the programs should interact with local health systems. Now, again, if you take the same figure, you can look at how this comprehensive health system strengthening should happen. It should really focus on the central axis of the system, that is health providers and the service delivery axis, and on not only targeted groups, because in fact we don't have really targeted groups. We are supposed to care for the whole of the population, of course, but also link up the linkages with the community And it can only be done probably if you really pay attention to the stewardship function. Which of course raises the question, what is then the stewardship function? And this is a definition which comes from, I think it's Lucy Gilson's definition in a sense. Okay, we talk about coordination of local actors, management, there is supervision and training, there is adaptation of national policies and guidelines. Would you call that stewardship, or is this just simply plain leadership and strategic management? And I think if we just stick to this definition, we should not use the word stewardship for it. Actually, stewardship is about safeguarding the public interest. It's about making sure that the whole system runs as efficient as possibly and as best managed as possibly, but always taking into account that healthcare providers, local health systems, national health systems have a social accountability towards the public. So stewardship is probably, at least a minima, this set of conditions. And then the question is, of course, quite often we know that vertical programs will kind of weaken that stewardship function and bypass it, which I think, of course, is no problem if there is no stewardship, because we should also recognize that in a lot of situations, there is not really a strong stewardship function. And then, of course, traditionally we would argue, well, it's important to invest in these stewardship capacities because it can actually strengthen the program's activities. And that's true, probably. But can the programs actually do that? And that's again a reference to the provocative statement in a sense. Do programs have the possibility to strengthen these stewardship capacities, and are they actually supposed to do it? Is it not a responsibility of other actors at a much higher level, and not just externally driven programs that are supposed to strengthen this key function of a health system? So I would like to thank my colleagues. Quite a number of them are here in the room, and open for questions.
I checked with our chair, and we can take up to 11, which is another big 15 minutes, more than 15 minutes for your reactions, your thoughts and comments on what you've heard so far. There's the keynote by Bruno, but perhaps also fitting what we heard before that in that framework. Yes, please.
Thank you for that keynote and all the preceding presentations. I just have a comment. I'd like to thank you, Dr. Marshall, for bringing back the focus to the word stewardship, because through the entire discussions from whenever we've talked about health systems, I think for this country especially, it might be my personal thing, but I think stewardship is the essence of what not only decision makers at the central level, but what has to percolate down to decision makers at every level of the health system, that stewardship is actually their role and function, in the sense that through my experiences with my work at local urban levels, I have seen that, we talked about integration earlier and how we can integrate services, and my colleague asked about how we can, if you're talking about integrating different disease control programs into a common data collection system, how is it possible? I've seen that this can be at least initiated at local levels when the local, in our terminology, it's ward medical officer, is empowered to know that he has the function to bring together these various players and to bring together these functions. So when it comes to involving the private sector, which are the local actors, players in the health system at that level, then to set up an integrated system of data collection where there is no duplication. So the personnel hired for a particular disease control program can maybe fulfill some of those roles, but the collection of data, the surveillance remains common. All these things we have seen happening at the local level in the area where I work, and it has been through the initiative of local ward medical officers who have been given to understand, or I don't know how they were empowered, but they know that they can do these things. And I think that's where the change needs to start, because at the central level, a lot of decisions can be made, and I know that there are a lot of intelligent people who can debate no end about health system strengthening, but unless our local level managers are given to understand the stewardship function that they have, I don't think we're going to see any change. We're just going to be discussing various models, but it's not rocket science, you know, in my head. I think it's pretty simple, and it can start at the local level. That's just what I'm saying based on my experience in the field.
Two more, and then leave Bruno the time to react altogether. Let me share a little bit the floor. Yes?
Thank you very much. I think I
Cambodia?
Yeah, from Cambodia. I think in terms looking at the health system strengthening, it's very difficult in the context of, you know, a country, especially more in terms of developing country where we are more dependent on donor-driven. And donor-driven, so the national budget allocation, as one keynote speaker already mentioned, that the contribution from the national budget is very low. So all vertical programs are very, very strong in terms of finance support. And if you look at the health system block, to ensure that it contributes to an overall health system, the fair, what we call a fair contribution on financing, it's not there. So, and most likely, the program that have more finance budget on their hand have more power, and the role responsibility is just to show their achievement, you know, fulfill their achievement, and drag or drain the workforce from other sectors to fulfill their achievement, and that's weakening the overall system.
Okay. I think you made a point, an important point. Let me quickly, Julie and then Marlene, quickly, and then we give the floor to Bruno. Oh, and perhaps we'll have time then still for a second round. Julie, try to keep it short, please. Marianne, I've written your name for the second.
Thank you for a great presentation. Just related to the first question, actually, I just wanted to ask, like, how does one go about developing stewardship in sort of very practical terms?
The how
you know,
question.
Is it just, you said it's oversight and regulation, but how do you actually build those into the health system?
Good. Marlene, let's keep it short. A microphone, please, for Marlene in the back.
Okay, I have to be short. So, Bruno, one thing you said, I would like to give a bit of nuance, because you said these vertical programs, at the beginning you said these vertical programs that fall on the neck of the community, as if all these programs are working on priorities that are not the community priorities. This is not the case. In our case study in Mali, okay, that is sometimes the case, but not always. There is very strong demand for AIDS care. There is strong demand for Kala Azar care in these communities. And the problem is, because how do we get from the current fragmented situation to stewardship at local level? The problem is that the communities, you can mobilize them on they mobilize on single disease issues. Yesterday we saw patients from lung cancer victims. So the demand is very difficult to mobilize on, we want integrated health systems. Do you understand me? Or how do you see that? Because for me, I can't see it very well. I can see how you can have patient organizations on single disease issues, but how the grassroots movements tackles this.
Thanks. Bruno, please.
Let me
we'll
start
have a second round.
Let me start with the last comment.
Yeah.
Well, first, I didn't say that these programs fall on the neck of communities. They fall on the neck of district health managers. And of course, I mean, I'm not questioning here or even doubting about the relevance of these programs. All of them have priority diseases as a focus. I'm convinced of that. The challenge is just how can you make, like in RDC Congo, that's an extreme example, 50+ vertical programs, how can you make sure that district health managers can deal with that? India has 15+, but I would be surprised if it's just 15. It must be much more, I think. And so the key challenge is how can you allow people on the ground to really deal with all these demands that are imposed by these really important programs? Because of course people suffer from these diseases. I'm not doubting about that. Second point on raising communities on single disease issues, yes. In fact, I don't think we need to to mobilize them for integrated health systems, but we need to mobilize them, and they actually mobilize themselves for social accountability. That's also a single issue. And you see that in Ghana, you see that in a number of countries. I think even in India, media are being used to raise issues, to mobilize people, to create awareness, but also the people themselves actually take to the media. So I don't see any problem, no contradiction there. Okay, we can discuss about that later, but the point is we're not claiming that we should mobilize communities for integrated systems, but social accountability is what counts in the whole thing. Then there are a few questions on, yes, the essence of stewardship, of course, and I agree with the first comment. You need stewardship at all kinds of levels, and I think it makes sense here to make the difference between stewardship at local level and the national kind of stewardships, which all fit within the broader governance arrangement. And that's why I don't like really the word leadership and the governance at that building block level, because governance, you can interpret it as corporate governance, as management of organizations. But let's stick to the more political interpretation of governance, which is setting up the legal frameworks, the organizational and institutional arrangements, the rules and procedures, the organizational culture that guides how systems work. And there's really a quite strong political science literature on that, and that is actually where the politics enter into the stewardship thing. So this governance environment kind of covers all of us and all of our institutions, and at the local level, what we need to do is recreate the right governance arrangements within our system through a good stewardship function. And of course the key question, I think that's if you get the answer, we'll start a consultancy agency, will be rich in 2 weeks. How do you get to local stewardship? And I think here, I have no solutions, but what seems kind of simplistically and a bit brutally simply perhaps say, what you see is what you get, and what you get is what you created, or what you allow to happen. So if we don't have good stewardship, for example, at local health system level, that's not by coincidence, I think. It's because the institutional order, the social order is as it is. Does that mean we cannot change it? I don't think so.
Okay, we'll go for second round. There is Marianne, there's the gentleman here, there's Karina. I take advantage of my position as chair just to come back to what something Marlene said, that it is not easy, not difficult, even impossible to create demand for an integrated service. That's how I understood it. Well, if the comparison is of course not entirely correct, but if we look at our own systems back home, well, if you look at the family practitioner, I think there is a very strong demand within the community, within patients, for a health worker that puts the bits and pieces together and that has somehow an integrated response to the problems of the patient. So I think, yes, there is evidence, the evidence that you have such a demand, that people want a service that is integrated and comprehensive. Good. Marianne, please.
Yeah. This issue is very much, at the heart of what we do with students in the Master of Public Health in Antwerp. I'm coordinating this master, and we have a master with this particularity that we have 2 orientations. One is they work on health systems management and policy, and the other one on disease control. And since 3 years now, we put these 2 profiles that represent these 2, the vertical and the horizontal logic, we put them together because we feel they have to learn to talk to each other and to understand each other's logic. And this is really a very good experience we have. We try to have them get insight in each other's logic and to document their own experiences. But then with regard to stewardship, I think also what we aim in these master courses is to empower these local cadres to be stronger in their negotiations with donors, for example. And we heard here about the need for documented case studies, and maybe as a case to illustrate how things can change is one of our former students. He's working in Ethiopia, and he started as a clinician in a project of a donor, an MSF-funded project working on leishmaniasis, and then he did a master course. And after the master course, he suddenly became the head of the National AIDS Program, something completely different from grassroots work up at the central level, being in charge of negotiations with donors and whatsoever. But he has been sensitized on all these health system issues, and I think later even he had the position of director of health systems even. And I think what he came back several times, he did even a PhD on his work. He came back to work with students, and also he could show them things are possible to change. And what they did, for example, in Ethiopia, they negotiated a human resource framework where funds were pooled from different programs, and they managed to convince HIV donors to use funds more flexible and really invest in human resources, invest in health information systems. So to see that things are also possible. That's
okay.
what the message
Through
is.
training. Okay, point taken. We really have, we still have a final debate at the end of the session. And so I see lots of fingers, but we also have to give due space to the second part of the session. So I'm going to take a last comment from the gentleman here, and then break for coffee.
I am working in research programs in Indian Council of Medical Research in India.
The mic, we can't hear you very well, yes.
So I am working in research programs in ICMR, Indian Council of Medical Research, as a senior deputy director. And we are doing a lot of research on mosquitoes and mosquito-borne diseases. As such, in India, health is the state subject. It is not, though national level programs are existing, health is the state subject. Whenever the priority comes, state will act into that. For example, epidemic in situations like dengue, chikungunya, they will immediately take the help of the nation, and then they will carry on. So the resource crunch is very, very minimal, number one. Number two, the national program has got its own target. For example, IDSP in TB control program, IDSP surveillance for the other vector-borne diseases like malaria, dengue, Kala-Azar, all diseases. In those kind of things, when you are interested to make a health system, how do you interpret with a comprehensive or integrated system? Whether it will work in developing countries like India. Because now the first thing is resource crunch. The second thing is national programs targeted is different. But at the same time, the political setup in each state, they never allow, the health ministry never allow the actual reporting system to the system. So these things are all the handicaps. How we are going to address these things.
Okay, thanks for sharing this. 30 seconds, Bruno, anything?
In fact, not much. I cannot really speak out on the Indian context because I don't really know that. Talk to Dave about it. But the point is, you get what you get, and I mean, what you see is what you get. What you get is what has been decided by people. Eh? You say programs have objectives, yes, but who set objectives?
Okay. On these words, I propose that we break for coffee and tea, and that we start again. Rupa? In 15 minutes, we start again at 11:15 sharp. Thank you.
Read it to us, right? Okay.